We've talked about what happens, what should we do with the surgery. Now we're going to talk about some of the things that we're thinking about. Once you have the spinal cord injury, what are the things that we can do to try to improve things? And so I'm really delighted to ask Frank Farhadi to give his talk on new trials and cell therapies for spinal cord injury.
Good afternoon, everybody. I'm Frank Farhadi. I'm at the University of Kentucky. So running a little bit behind, I'm going to go quick. I've been tasked to offer you a sort of a high-level overview of cell therapies for management of acute traumatic spinal cord injury. This entire literature is really based on a wealth of preclinical data, which we're not going to get into. Overall, the whole point of this sort of field is trying to obviously mimic what you see in this MRI. And basically what you're seeing is the typical scenario. There is a cystic cavitation related to the sequelae of a severe spinal cord injury, and there's a varying degree of tissue bridging, as you can see, that's still present. So obviously there's preserved function still there. So as you know, the spinal cord injury itself goes in various stages. There's the primary injury, which we all are familiar with. The secondary injury is ongoing over the next hours and days and encompasses a variety of areas, including inflammation, excitotoxicity, and obviously programmed cell death. And we also can't forget the fact that there's a chronic phase. And in the chronic phase, there's scarring. It's particularly in humans, there's cyst formation, ongoing inflammation, arachnoiditis, and tethering. And these cell therapies, with varying degrees, depending on when you administer them, how much you administer, whether you do concomitant immunosuppression, where you administer it, is meant to curtail or maybe even reverse some of these issues. So, especially in the preclinical world, the microenvironment modulation is an important theme, and these cells, depending on the identity, have been shown to do that. So preservation, promotion of cell integration, neurotrophic factor support, and signaling. And the archetypal version cell that's been shown to do that is the mesenchymal stem cell. Fighting inflammation is an important factor in this, and neutrophils and macrophage, microglia-mediated reduction is important. Regeneration is something that obviously can help in the more later stages, and axonal growth remyelination, synapse formation. So you can't really talk about any of these, this entire field without starting with the Miami work. The first two rows refer to both the subacute and the chronic studies that was done by the Miami group. All of these studies were primarily designed to assess for safety. And in fact, these Schwann cells derived from the patient in vitro amplified and then re-injected has been shown to be a feasible paradigm and safe as well with proper follow-up. The lower row refers to a paper out of South Korea, which was powered to identify potential efficacy, but didn't show efficacy, but at least it was fairly safe similarly, and it related to the use of bone marrow-derived mesenchymal cells derived from the patients. The second slide here focuses on neural stem cells. So neural stem cells, these are have been used at various time points, both either a few months or beyond a year after the injury, and also similarly have been shown to be safe without significant sequelae in terms of causing further injury or mass lesions. This study bears mention done by Dr. Fessler using a commercially available embryonic stem cell-derived progenitor cell line, and similarly using A or B injuries in the cervical cord, intraparenchymal injection in particular with immunosuppression has been shown to be well tolerated. And at 1 year follow-up, there was a standard conversion that I think was interesting, but certainly not conclusive. CellTop is something from Mayo Clinic. Dr. Biden's here. I believe that his study is still ongoing as a second phase related to showing maybe early efficacy. And finally, I just want to talk briefly about duroplasty. Duroplasty, I know Dr. Arabi mentioned this. We are going to use duroplasty as an adjunct to a study that we're about to start where we're going to actually evaluate the potential safety and early efficacy of autologous peripheral nerve grafts. And this is using and sort of piggybacking on the work that's been done by my colleagues at the University of Kentucky, Dr. Van Horn and Gerhardt. Actually, wealth of patients at this point using their DBS plus paradigm. They've shown that these cells last, survive, thrive inside the brain, and we're going to be doing something similar inside the spinal cord, where we're going to implant it after a small myelotomy using the patient's own sural nerve, and we're going to also incorporate dural patching along with this as an added safety measure. We're going to be following patients for 12 months, double-arm study with monitoring, and we're going to evaluate safety and preliminary efficacy. This is just a broad overview of what's out there in terms of potential studies related to cell therapy. And everybody talks of the valley of death. In this area is particularly prone to it. I think we're at a crossroads with regard to the cell-based therapies for spinal cord injury. Hopefully, as we embark on this next phase, we'll really carefully evaluate what paradigm best suits patients in terms of promoting recovery. Thank you.